background of who we are, I'm a speech-language pathologist.
I'm a licensed professional counselor and art therapist.
And I'm a board-certified behavior analyst.
So at Blossom, we're an interdisciplinary center, and we provide services primarily early intervention, birth to 8, for children on the spectrum. We provide speech therapy, occupational therapy, ABA therapy, and counseling and art therapy at our center. We base all of our teaching in a naturalistic setting, so we really work with our kids through play, in classroom settings, and really how we try to base our program off of how preschool might be so that they're ready when they get ready to go to school. And then we have a new location in Brighton, and then our original location is in Novi. So that's where we are giving all of those services.
Alright, so I'm gonna begin with talking a little bit more about what autism is and what the symptomology looks like. So make sure I'm on the same slides. Okay, so what is autism spectrum disorder? It's a neurological and developmental disorder that impacts an individual's ability to communicate and interact with others, in all of their different environments. So whether it's at school, at home, in the community, it impacts their ability to interact with them. Some signs of autism are present in early childhood and remain throughout the person's life. Symptoms may improve over time, but there is no cure for autism. Now, there were some changes to the DSM-5 diagnostic criteria. And so now when we talk about autism, we talk about it in regards to a spectrum. So the spectrum is a broad range of individual abilities and deficits requiring varying levels of support and intervention. And according to the most recent version, the diagnosis is now more accurate. Previously, there were a number of different disorders that were accounted for within the spectrum. So we had autistic disorder, Asperger's syndrome, childhood disintegrative disorder, or pervasive developmental disorder, not otherwise specified. And you typically will hear that as PDD and OS, but now they're all included within the spectrum. Each of those 4 diagnoses were just varying levels of severity and symptomology, but now it's all combined together. So any person that would have previously been diagnosed with any of the 4 other diagnoses should still meet the criteria for autism spectrum disorder. Some early signs and symptoms that you may see in individuals. We have social and communication deficits that you may see, including not responding to their name, poor attention or eye contact, reduced sharing of emotions, no sharing of toys or their interests. They prefer to play alone a lot of the time, and no use of gestures or understanding the use of gestures from others. And a lot of times there's that difficulty with engagement as well. And I want to clarify, this isn't an all-inclusive list. This is just some of the things that you'll see most commonly. And as far as the restrictive and repetitive behaviors or interests, we have echolalia and rote language. And those will be further elaborated on by Mackenzie. We have repetitive motor movements, resistant to change, fixated interest and rigidity. They refer to themselves by their own name, not often using those pronouns appropriately, and then you may also see hyper or hyporeactivity to sensory input. Okay, so for the criteria, I'm gonna read off the specific criteria that must be met in order to receive autism spectrum disorder diagnosis. There are 2 main domains or criterion that you must meet overall, but within each of those domains there are other specific criteria that you must meet. So for domain A, we have persistent deficits in social communication and social interaction across multiple contexts, not accounted for by general developmental delays. And so there are 3 subdomains within domain A, and all 3 must be met in order to receive the diagnosis. So for A1, it really reflects on like deficits in social initiation and response. So we have deficits in social emotional reciprocity, ranging from abnormal social approach or failure of normal back and forth conversations or interactions, to reduce sharing of interests, emotions, or affect, as well as failure to initiate or respond to social interactions, and that can be from their peers or adults in their environments. For A2, there's deficits in nonverbal communicative behaviors used for social interaction, ranging from poorly integrated verbal and nonverbal communication, to abnormalities in eye contact and body language, or deficits in understanding and use of gestures. And then for A3, which focuses on deficits in social awareness and insight, the deficits more specifically in developing and maintaining and understanding relationships, difficulty adjusting behavior to suit various contexts, and difficulties in sharing imaginative play and in making friends, and absences and interest in their peers. And again, all three criteria must be met for that one. And then we have domain B, where we're focusing on restricted, repetitive patterns of behavior, interests, or activities as manifested by at least 2 of the 4 symptoms. So of the 4 subdomains, at least 2 behaviors or deficits must be observed in order to receive that diagnosis. So we have B1, stereotyped or repetitive motor movements, use of objects or speech. Some examples could be simple motor stereotypies like hand flapping, lining up toys, flipping objects, echolalia, and things like that. For B2, insistence on sameness or inflexibility and adherence to routines, ritualized patterns of verbal or nonverbal behavior, which could be observed as extreme distress due to small changes in their schedule or routine, difficulties with transitions, and like really rigid thinking patterns. And for B3, we have highly restricted fixated interests that are abnormal in intensity or focus. So they have this extreme attachment or preoccupation with a person or an item, excessively circumscribed or perceptive interests. So they focus on a topic and then it's really hard to redirect their interest from that topic and like talk to them about something else, because they're like, this is what I want to talk about and that's all I'm going to talk about. And then we have B4, hyper or hyporeactivity to sensory input or unusual interest in sensory aspects of the environment. So a lot of that is like extremely high tolerance for pain, or a very, very low tolerance for pain, or a visual fixation with like lights or shadows and things like that. I don't know what else. There it goes. Sorry about that. I don't know what I did, but I did. When you're thinking about the diagnostic criteria, there are a few things that you need to keep in mind. So you want to avoid using the same exact behavioral example to satisfy more than one criteria. So if I'm thinking about motor movements and or my social interactions, and I say like, oh, well, I don't respond to hi, or I don't initiate greetings, I don't want to use that same criteria or that same behavior for multiple criteria within the diagnostic test, I would say, or assessment, because then that could just be a typical or a normal developmental delay. I don't want to say normal, but like it could be a typical developmental delay that isn't associated with autism, and it could evolve over time. Behavior that are not currently observed may be considered as well. So if you have someone that's say 10 years old, and they're currently interacting with their peers a little bit better, but in the past they didn't interact with their peers much, you can use what was observed when they were younger to satisfy the criteria. For early childhood, that typically refers to children 8 years of age or younger, and diagnosis may occur beyond early childhood. Early intervention is key, but you can still receive a diagnosis beyond the ages of 8. And then typically as the social demands begin to exceed the individual's current abilities, people are more aware of some of those signs and symptoms that that the individuals are engaging in that lead them to believe they may have autism. Now I'll go over some current statistics. I don't know what's up with my words right now, but some current statistics. Overall prevalence of autism is 1 in 44. So that it's much more prevalent now than it was in years past. And I do think it has a little bit to do with all of the 4 diagnoses being on the spectrum, and more awareness to what autism is. For boys and girls, boys are more likely to be diagnosed with autism than girls are. And there are no differences amongst racial, ethnic, or socioeconomic status. Autism is present across all domains, people. And then as far as older parents go, children born to older parents are more likely to receive a diagnosis of autism. Here are some other risk factors. So genetics plays a huge role in, sorry.
I just have a question as far as the older parents. So what does that look like as far as like age? What would you consider like older?
So when I was doing like my research about it, it's typically those late 30s, early 40s, and beyond that. Yes.
I was just wondering if, just a quick definition of echolalia.
So our speech therapist, Mackenzie, will give like a brilliant definition of that, much better than I would ever do.
I was just wondering, in your research, did it give you any information regarding when autism spiked, or is it that they just start diagnosing it?
It didn't give any like clear like definition or anything about when it spiked or like why. This is my opinion. Like I believe that you see more of it now because there is a greater awareness of it. And then also the change in how you're diagnosing is more like prevalent. The doctors that are prescribing it have a better understanding of what the diagnosis looks like. So I think that has something to do with it, but I can't say for sure.
A lot of kids previously would get misdiagnosed or diagnosed with other disorders, and now we're starting to see, oh, that was autism that was present then. Mm-hmm. So just being early identification has been a key part in that too.
And it's commonly co-occurring with other disorders too. So.
Just one more.
Yeah.
So overall, what is it that you want the program that you're dealing with? I mean, that you run, and then the people with autism to ultimately do? I'm just curious.
For most of our programs, like we just want to improve their quality of life. So we want to support them, we want to support their families, and provide those resources for them so that they can navigate the spaces, their environments, classrooms, wherever they are, in a functional way, and just be able to engage and interact with people and live a good life.
Thank you.
Yeah, a lot of our program works on just adapting to like a classroom environment or interacting with their peers or using, like as a speech language pathologist, I'll help develop their words and help them get a communication modality so that when they go to school they have a way to express their wants and needs. And then an occupational therapist would work on helping like giving coping strategies for some of those sensory differences, behavior, and BCBAs would work on like helping reduce some severe behaviors that they might have to help them better interact in their environments.
Yeah, and so the Blossom method per se is about looking at helping the child as a whole child. So whether it's giving the parents, giving the parents more of an opportunity to understand, right? And then an overall acceptance. So it's not that we want to change the children or anything, it's more about meeting them where they're at and then kind of developing a way for them to feel comfortable and kind of progressing in life. Because it's early intervention, so we got like itty bitty guys that are in our center right now.
Thank you.
Yep.
So when it comes to genetics, there is a component of that that impacts the diagnosis of autism. So there are inherited genetic mutations or spontaneously occurring ones. Some disorders that are associated with autism that might impact the severity of its symptomology include Fragile X syndrome and Rett syndrome. Fragile X syndrome is it's seen more often in boys, and Rett syndrome is seen more often in girls. And they're both different types of genetic disorders that impact development and brain functioning. As far as environment goes, there is current research that is exploring the correlation of viral infections, medications, any complications during pregnancy, and air pollutants on autism. And for family history, the risk is greater for those with family members that also have a diagnosis of autism. Some other disorders as like described within genetics, like Fragile X syndrome, intellectual disability, ADHD, those are some other risk factors. And then preterm babies, we see an uptick in preterm babies that are diagnosed with autism. So when it comes to screening, the screening process typically begins with developmental monitoring and screening, followed by a formal evaluation. And when it comes to monitoring and screening, those usually happen during the well-child visits. So when the child is going to see their pediatrician for their 6-month checkups, their yearly checkups, and things like that, that's when you will, parents are typically asked to fill out questionnaires to provide insight on their developmental milestones and how they're doing at home, or if they're in a preschool setting or daycare. And then we have the Autism Diagnostic Observation Schedule, also known as the ADOS, which is an activity-based assessment, and it's administered by trained clinicians to evaluate individuals who are suspected to have autism. And then just a few examples of some other screening tools that are used. We have the ASQ, also known as Ages and Stages Questionnaire, Parents' Evaluation of Developmental Status, and the Modified Checklist for Autism in Toddlers. So as I said before, there is no cure for autism and no preventative measures that anyone can take. However, there are treatment options and intervention options that do seek to minimize the severity of symptoms and improve the individual's quality of life. When thinking about a treatment plan, we want to make sure that those plans are individualized to support the needs of that specific person, because there is no one-size-fits-all plan for anyone. And of course, early intervention is key. So some of our therapeutic support, so we have the ABA, and that's what I do as a behavior analyst, which is a one-on-one treatment approach that applies the understanding of behavior change to increase skill acquisition and reduce the occurrence of maladaptive behaviors. And then we have speech and language therapy, which helps to improve a person's understanding of both receptive and expressive language, and then also to be able to use that language as well. We have art therapy, which is a specialized form of psychotherapy that encourages self-expression and creativity through visual arts. Some other therapies as well, occupational therapy, which involves the therapeutic use of everyday activities to treat physical, mental, developmental, and sensory challenges that impacts a person's ability to perform day-to-day tasks. Physical therapy aims to ease pain and improve daily functions through increased mobility. And then we have play therapy, which is another form of psychotherapy that uses play to aid and support children through self-expression, prevention, and resolution of child-specific difficulties. Now Mackenzie will come and talk about communication strategies and supports.
And one thing I just want to highlight when you're looking at all of those criteria for how a child might qualify for autism, you won't see, when you meet an autistic child or adult, you have met one autistic child or adult. Everybody looks different. You won't see the same qualities in every person. So it's very important to have an individualized plan and approach when you're working with an autistic adult or child. And I'm going to use identity first language because that's what the autistic community has expressed that they prefer, instead of child person first language. So as a speech language pathologist, it's communication. So receptive language is what you're understanding, verbal and nonverbal language. Autistic students may need additional support to understand verbal instructions or questions that you might ask or have for them. And then there are different levels of complexity. So communication starts from gestures, single words, phrases, sentences, questions. There's just different levels of complexity when it comes to our language. And sometimes we don't think about it when we don't have these difficulties ourselves. So thinking about what level our child or the youth that we're working with might be at for their language is really important. Some strategies to support reduced receptive language skills would be first to just simplify your language. If you notice that a youth isn't or a student isn't understanding what you're saying, maybe try to think about how you're asking it and make it simpler or more concrete. Breaking instructions into single steps. This is another thing that like in classrooms typically a teacher might say like, okay, go grab your backpack, get your folder out and come meet us at the circle time. That's 3 single step directions that might be really hard for an autistic child to understand. They might just need it one at a time. Like first go get your backpack, then get your folder, and then like one at a time just to make it so that they're more successful with the instruction. Again, these won't apply to every autistic child, but these are just some things to look out for. Gestures and visuals are really supportive, so using gestures like pointing, pairing your words with like your body language is giving an extra way for them to understand it. And then using pictures, so at our center we pair visuals with our instructions as well to help. Again, it's just another way for them to understand what you might be asking. And then give wait time before you're repeating yourself. So this can be a big thing as adults or as communicators when we don't have difficulties understanding and using language, we tend to repeat ourselves, thinking that that might help. And sometimes our students might just need they just need more time to process the instructions you're giving them. So before, maybe just ask like if they're understanding, and before you repeat yourself, just give them an extra beat. Expressive language is what verbal and nonverbal communication a student uses to express themselves. So a big criteria in getting diagnosed with autism is delays in receptive and expressive language. So a lot of our children will develop verbal language later and may not go on to develop verbal language. So expressive language would include augmentative and alternative communication. I'm not sure how familiar everybody is with these terms, but AAC is just a different form of communication. So we might use pictures. So if you've heard of PECS, there's picture exchange communication systems. A student might have an iPad that has icons on it that they use to talk. Using gestures like modified sign language. Some children get introduced to language by using some signs, and then even just using other gestures like pointing or nodding and shaking their head, like that might be an alternative to verbal language. And these might be used for the length of their life. They might be using this for long term, or it might just be a short term use of communication until those words come, or until they're more consistent with their words. And another thing that we see a lot in autistic children is that when they're upset or dysregulated, they have a decrease in their use of words. So sometimes using different ways to express themselves or having strategies for that might help them get those words out when they're having a hard time in an environment that they're in. So it's nice to have different options. These are some examples of AAC. So the first one on the left is just a choice board. So it could be just a help for them to select their want or need. And then the one on the right is, we call this a core board. So this might be on a tablet, or sometimes we just have this laminated and bring it around with our students, and it's just another visual. So a lot of these are multisensory. Autistic children and adults tend to benefit from multisensory teaching. So hearing it, seeing it, touching it would be a way to do this. So if this was a tablet and I wanted to say like, I want to go, I could just press like want, go, and if it was a device, it would verbally say the word for them. Or if you just had it as a laminated sheet, you could just use those as well. So it's just another visual. So if you have a child who's using a device like this, or using a core board or something, having that as a support for receptive language to what they're understanding is helpful too. Like if you're asking them if they want to go, you could always like using how they're best learning is a good way to do it too. So like pointing to the icon. We have big icons around our center everywhere, so I don't know if they have a go.
Might want to pass them.
Oh yeah, good. So like we have go on like most of our doors, so that if we have a child who's nonverbal or pre-verbal, they can just touch it and just like point to it to show us that they want to go. We have that on shoes off, things like that. to promote expressive language. So a big thing as a speech language pathologist, I'm trying to teach parents and their support, people in their environment who are supporting them, to just accept and respond to all types of communication. We don't want to say like, use your words, like this, or say, go. That's a way to teach them how to do it, but if that's not the way that they can express themselves, is really have to be responsive to all types of communication. So looking for their eye contact, looking at their gestures, their body language, smiles, their verbal words. Like if there's some of our autistic kids are really like hyperlexic, they are really good at writing and reading and writing. So that can be a good way if that's the way that they like to communicate. Again, it's going to be different for every student you interact with, but trying to figure out what works best for them. And then always ask for clarification if you don't understand something. A big strategy I try to teach parents for pre-verbal or minimally verbal children is helping to narrate their actions with words. So I always say, like, read their screen. If a child had a screen on their head that was saying what they were thinking about, and trying to really be observant of what they're looking at, what they could be thinking about, what they're interested in, and give them those words. So if we have a student who's not talking and they're looking at the train and saying, like, oh, I see the train, like the train goes choo-choo, and trying to give them, like, if they were saying words, what words would they be saying, and trying to really think about it from their perspective. I always like to comment over questions. Questions can be, there's only one answer, and if you comment, you might open up a topic to discuss with this child. And again, if they use echolalia, which I'm going to get to in the next slide, it can be something that they can repeat, which makes this functional language. Offering choices visually and verbally is a great way to support children with delayed expressive language. So, like, water, do you want water, or do you want juice? Instead of saying, what do you want? That makes it a little bit more concrete, gives them choices. And then again, if they have a hard time with verbal words, understanding verbal words, giving them pictures or just holding it up for them and seeing what they point to or want. And then always asking caregivers about communication with their child. And then if they have a device, like I said, like a tablet or a textbook, always asking how they use it at home, and just even keeping it available. Like accessibility to those is really big, just so that they always have it with them so they can use it when they need it. So Jasmine talked a little bit about social communication differences. I'm going to go a little further into depth with this. It is a core difference in our students' learning. So a lot of kids have delayed expressive and receptive language. That doesn't mean they have autism. A big piece of it is using their language to connect with others. So getting your attention might be difficult, or gaining their attention. So if you say, like Johnny doesn't turn to look at you, and both ways, if Johnny wants your attention, he might have a really hard time using what neurotypicals would consider normal ways to get our attention. Might be hard for them. So they might not use your name, they might not have eye contact, a student might not turn to you when they're talking to you, they may just talk. So getting your attention might be hard, so that's why we have to be really responsive and observant for when we identify a child on the spectrum. Many students have a difficult time with figurative language or jokes, so sarcasm can be really hard for them to pick up on or interpret. Our autistic students are really literal thinkers, so they're going to take the joke, they're going to take the words meaning for meaning. That can be a hard thing, so a lot of our students have to be taught specifically jokes and what they mean and how to use them appropriately with peers. A lot of kids might not know that they may not know that they're getting bullied because they just don't understand how that's happening in their environment. Playing or interacting with peers might also be difficult. Like Jasmine said, a lot of our students have really fixed interests. They really like the train. So sharing the train with somebody else can be really difficult, and two, understanding like she likes dolls. Like that's absolutely not. We have to use the train, so that just might be a hard thing. So a big part of our job too is helping our students learn how to share those interests with peers, and like accepting other ideas and being able to incorporate different play ideas. Eye contact also might be difficult. This is something we try not to push. It can bring up a lot of feelings of anxiety and stress in our students. But it may or may not be something that's stressful for them, but it's just something like if they're looking at the floor and talking to you, that's okay. That's just how that they can get their words out. It might be a demand, expecting them to use their words and look at you might be a demand that's just too much for their system. It might be too hard for them to then use their words and use their eyes. I lost it, Jasmine. Oh, you did it so good. And then accepting or incorporating different ideas. I kind of touched on that already. Some strategies for improving or helping students use their social skills would be keeping language at their level. So if you have a child who's using single words or phrases, keeping your instructions and your communication at single words and phrases is a good way to do it too. I always like to say like the one-up rule. So if they're using 2 words, like giving them a model in 3 words is great. But just asking lengthy questions or telling lengthy stories is it's gonna be a hard way to connect or engage with a student. Keeping your language literal and concrete, saying what you mean and keeping it very clear. Again, like the choices, just say, what are you thinking you want? Do you want some water? Do you want some juice? Like maybe just saying water or juice, or showing it to them might be a good way to keep the interaction going. I said don't expect eye gaze when talking. Look out for any types of communication and response. So if you're near a student and you hear them talking, maybe take that as a social interaction from them and respond. And also, initiation of social interactions might be difficult, so think about initiating those yourself. Offer opportunities to engage with others and encourage sharing space and materials. So if you notice that there's a student who is really playing with the train and it looks like they might want to connect with their peers, give them some ideas of how they could do that. You can go show Jasmine your train, or you could say, hey Jasmine, look at my train, just to give some, this is how we could introduce this play idea to another peer. And then go along with their ideas and introduce new ideas once you have a good foundation. So a great way to build engagement and a relationship with anybody is showing interest in what they're interested in. So even if it's like Jasmine said, one of those fixed interests, or it's really, the student really just wants to talk about the ceiling fan or trains, like I said, go talk about ceiling fans. Like what else can you say about ceiling fans? Can you find other things that spin? Can you find other things that you can turn on and off? Can you find things that have a light and spin? Like just trying to be creative about how you can incorporate their interest into the environment. And then once you have that relationship built, see if you can expand it. You can take that activity and apply it to in other environments or with other people. Find somebody else who really likes fans or trains or who wants to talk about that stuff as well. Echolalia. Oh yeah, sorry.
I was just curious about, is there any research about auditory processing disorder with autism?
Yes, there is a lot. We tend to see our autistic students a lot of them have auditory processing disorder. That's why I said giving wait time, giving the visuals can be really helpful. And that would be in their receptive language, so them understanding language, having a harder time understanding language would be because of the processing time and not being able to quite understand the verbal language that they're hearing, or just needing some support with it. Echolalia there are 2 types. A broad definition is that they just repeat, a student might repeat what they hear. So immediate echolalia would be like I say, hey, how are you? And Johnny says, hey, how are you? Delayed would be I say, hey, how are you? And someone says good, and then maybe 10 minutes later, the student repeats it again in the same tone. So, hey, how are you? Just how I said it, just how they heard it in a different context. This may or may not be what a student really wants to say. So that's what can be tricky with echolalia. There's a variety of reasons why a student or an autistic child might use echolalia. It could be they're processing it again. It could be they need to repeat it so that they hear it one more time to themselves, so that they can generate a response. It can also be, it might buy them more time. So if they repeat it to you, it gives them a little bit more time to generate the response that they want. It can be them telling you that they're with you. It can be a way for interaction. So they're echoing what you say because they're saying I'm here, I'm with you, I'm connecting with you. Because social interactions can be difficult, that can just be oh, I can repeat this and I can let them know I'm interested. It just can be communication. If you say, do you want water? And they say, do you want water? And they're nodding their head, that could be an affirmative, yeah, they want water. And if you say, do you want water? And they're like, water, and just repeat that might be a no. And it also can be a self-regulation strategy. So if you have a student who's getting escalated or having a hard time repeating things to themselves or repeating what they hear, might be a way for them to get themselves, a strategy for them to calm themselves down. Scripting is in the same realm. It's when a student repeats the language they previously heard from a different context. So we see this a lot with TV shows, movies, parent language, songs. So you might have a student who just uses lines of language from something they previously heard. The reasoning is the same as above. This can be really entertaining for our friends. They might just really like it. Like they really like watching Octonauts, and so they're gonna script Octonauts for you. It can also be tied to strong emotions. So like if they were at home and their mom said, "Oh, look who's here," and it was grandma, and they love grandma. When they get really excited in a different environment, they say, "Oh, look who's here," and that's them. They're not expressing the emotion, saying, "I'm really excited," but that's what they're saying. They took that feeling. I felt really excited when grandma came over, and that's what language I heard. I'm going to use that language here because I'm feeling excited again. And then again, it can be self-regulation. So if we see this a lot. If a social environment is really overwhelming, they might be scripting something to themselves because they know what to expect. They know what the words are. They've memorized it. They can picture it in their head, and it helps them be able to stay in that environment that might be hard or stressful. To decode what the meaning might be, I always say, like, if you offered a choice, use a visual to make sure that you can see what they're pointing to. If you know your child is echolalic, and always look for body language. Like I said before, if they're saying, "Do you want water?" and then say, "Do you want water?" and they're reaching their hands out, just using more than just the words that they're saying, like reading the whole person. Pay attention to the repetitive language that they have and just ask questions. If they're too young to answer it for themselves, like ask their caregivers, like, "Hey, they keep saying this, where's that from?" So that you might get a better idea of what they're trying to communicate when they use that script. Or ask them if they're old enough, like, "Hey, you say that a lot, like, where is that from? Why are you saying, like, what does that mean?" Accepting echolalia and scripting as meaningful interaction, like it really could be their way of connecting and trying to stay with you in the moment. But I like when that happens, I like to connect the script to a real-time activity. So also use accepting that, and that is a functional and clear communication for them, but also giving them another way that they could say it, like, "Yeah, I see you're really excited." If they say, like, "Look who's here," if they say, like, "Hi, how are you?" Responding how you would, just keep the conversation going and treat it as functional language. Stop, wait, listen, and respond. So a big strategy with more as they get old children who are echolalic is to wait for them to initiate. We don't always want to put words in our students' mouths. We want to wait for them to initiate so that they can generate what they want. Again, it might take longer for that verbal response to come, but initiation can be a big thing if you just wait for them to say what they want to say first, and then you can respond. Narrating the emotions, like I just said, so giving them those emotion words, which can be really hard for them to access. And then limiting questions when they express a need and increase your comments. So like Jasmine said, a lot of our autistic students use their name, and that's probably because other people around them are using their name all the time. Like, "Oh, Johnny really likes the train." So then when he likes the train, he says, "Johnny really likes the train," because he's heard it before. But if you say, yeah, you can say, "I like the train," or just modeling it with those pronouns, so they're like, "Oh, I like the train." A lot of our kids who have reduced expressive and receptive language get questioned a lot. So you see, because people are trying to figure out how to communicate with them, so they might say, like, when they want water, they might say, "Do you want water?" and come up to you and say it that way, because that's how people always say it to them. Like, people are always asking questions. They're always asking yes/no questions. So that's what they've learned. Like, okay, when I want water, someone says, "Do you want water?" So that's a big one too. And another thing would be changing, if you give them a choice, especially, I see this with yes/no questions a lot. Children will stick with one answer. They'll always say yes, or they'll always say no. Switching the order. So if they're only repeating the last word you say, like they're only saying, "Do you want juice or do you want water?" They say water. If you know that they tend to have echolalia, switching it, like, "Do you want water or juice?" And if they repeat juice, then like definitely show them both. But if they say water again, then you know, like, that's what they want. Just to make sure that they're getting their needs and wants met. Did that answer your question about echolalia? Some communication strategies during dysregulation. So I feel that you're all familiar with regulation, dysregulation. Okay, I just want to read the room. So we use the zones of regulation a lot with our students. This can be when an autistic child is dysregulated. It's really hard to access language. It's hard for any of us to access language when we're in a dysregulated state. But like some big strategies would be give wait time. Just wait. Let them know that you're there for them. I'm here when you're ready. Offer choices, like if a child is getting dysregulated because of a transition that's coming up, maybe give them choices like, we can walk or we can skip to the gym, or we can take the train, or we can take the doll with us to this next thing that might be stressful. Providing visuals, again, if that if they have a hard time understanding your language when they're regulated, when they're dysregulated, it's gonna be very difficult, so giving them visuals that you can show them for them to either use or just understand your instructions better. Reducing your language and your volume is always a big one, so like if a child starts getting escalated, being louder isn't gonna help. We try to like lower our voices and reduce the language in general. That would be when we go from a question like, do you want water? Just like, water, I'm here. Just keeping it clear and simple, and less is more in those moments. Creating a visual or a written schedule might help a student who has a hard time with transitions. So just writing out like, first we have the gym, then we have this task, or then we have this task, just so that they have an idea in their head of what's upcoming. Or if they're dysregulated, it might be something that like, as they calm down, they can reference it and be like, okay, this is what I can expect, this is what I know is gonna happen. Find the why. Every behavior is communication, so figure out like, was it a demand that was too much? Is it the environment they're in that's too much? Try to help the environment be a better learning space for them. And then always keep a calm voice and a calm body. A dysregulated adult can't regulate a dysregulated child, so if you need someone to step in, that's totally cool. And then also if just being mindful of like your voice and your body when you're interacting. Some strategies to support regulation. I always ask parents about sensory needs. So a lot of our autistic children have, like Jasmine mentioned, they have experienced the environment differently than we might. The lights might be brighter, the sounds might be louder. There might be things, the texture of the clothes might be hard, and it's something we don't, as neurotypicals, don't experience. Like our brains have taught us that's something we can ignore, but our autistic friends, that's not something their brain is ignoring. It's something that's really big focus for them. So trying to ask parents about, and it's different for everybody. It's not gonna be the same for any student. So asking their parents about if they have any sensory needs, if there are ways that you can modify the environment to make it easier for them to interact. I always like to use timers. That's something to help, like timers to count down when the next activity is coming. So if you know that they have a hard time putting the train away, you can say, okay, like set a timer on your phone, be like, in 5 minutes we have to put the train away, and then we have to go, or we have to do this. And that kind of explains verbal previewing, just giving them an idea of what's coming next. To help so that they can keep it in their mind, and if that upcoming stressor isn't as stressful for them. Environmental adaptations, like I said, and sensory support. So some sensory supports, I don't know if you guys are familiar with these, but like some kids have the noise is too much, so we have noise canceling headphones. Like weighted blankets might help reduce some of those sensory differences that they have to help them help a student interact better. Even just having a room that they can go to that's like a break room, that's quiet, and they have things that they enjoy in there that just might be a nice break for them. We use a break icon a lot. Like something's too much, let's take a break, let's go for a walk, let's come back. And then relationship first, so I'm sure you guys are all really familiar with this, but just with like working with any child, building trust and relationship is the key to getting communication out of our autistic friends. Always engagement first, be interested in what they're interested in to start and build your relationship. Observe, watch, and listen, so observe their behaviors, their attention, what they're interested in, what types of communication you're noticing they're doing with their peers and with you. Listen to what they have to say, and join in with their ideas and interests. I always say be a helpful play partner. Like let's make it easier for them, not harder. So if it's already hard to engage socially, let's try to figure out how we can make that interaction easier. Take it slow. It typically takes a longer time to build relationship and engage with our autistic friends than it would a neurotypical. So just give them more time to build that relationship with you, and don't expect change the next day. It takes time, but just because an autistic student has difficulty interacting doesn't mean they don't want to interact. They do want to interact. It's just figuring out how to make that happen is what they really are working on. And then try to understand, accept, and observe their sensory needs and their communication.
I have a question, well, kind of a comment. We have a youth who is 16, 17, I think, and he was diagnosed with ASD. His parents, for cultural reasons, have kind of refused to accept that diagnosis. So like it's been tricky in like making sure he has like the things that he needs, or like communicating with them about certain things. And then like we've tried to do a lot of different things as far as like working with him. Like we actually switched like he's in a residential facility, so like they're graded on like a different scale, but we had created like a visual chart for him to see, like he'd get gold stars versus like comments from the staff, and that kind of helped for a little bit. But we still have like trouble sometimes like working with him and the parents as far as like the things he needs. And you're talking about like relationships and stuff, but we've been working with him 6-7 months in the facility, a little longer as far as like probation and stuff goes. I wasn't sure if you guys had any suggestions for like parents who are unwilling.
That's the next part.
Oh.
Transition. Liz has lots to say.
Transition. That was not paid for.
Liz has lots to say about the transition.
And I told Mackenzie, that was the perfect last slide to go into this. So, how many of you have a similar experience to what she's kind of explaining? Or maybe have an idea that maybe there's, okay, I figured, okay. So I'm a licensed professional counselor and art therapist. Some of the stuff that I provide at Blossom are support groups, and some psychoeducation for parents as well, and then giving some family sessions to kind of help facilitate that bond. It is very tricky when you have that barrier of treatment, when you have parents that don't want to fully accept. So it is a process, and it probably is a lot more difficult too when you have their child also in a residential facility. Can we circle back to it at the end? Okay, because I think there might be some ways that we can go for that particular youth. So yes, we have to meet our parents where they're at. So as we know when we're working with any sort of adolescent or youth, we are really working with the whole family, right? So that's also the most difficult part too sometimes when we're working with our children or adolescents. How old are the clients that you guys usually see? How old do they get? 14 to 19? Okay, all right.
Sometimes a little, there's a couple outliers.
Oh, I'm sure. Okay. So I used to work residential too, so I can kind of understand with that too. So if you don't have a huge relationship with the parent, it is going to be pretty hard to get that facilitating the bond with the child, and then also having them have that co-regulation and support too at home. So with you being like a direct worker with the client, I think being there and being supportive with the client and being that one person might do a lot more wonders too as well than if the parent isn't fully accepting right now.
Well, I will say he's somewhat dismissive of it too, but I think that's just because of how, he was raised and stuff. Like,
Sure.
when he first came to the facility, he would make a lot of comments of like, I want to make sure people don't know that I'm slow, and like I don't want them to treat me any differently. So like, it even took us a minute to be like, this is what we, from our outside looking in, think will be more helpful to you. So like, he bought into like the things
Okay.
that we kind of did, but then there's a lot of back and forth with like, he'll be on board with one thing when it's just us, and then the parents come into the picture, and it's.
Why? Yeah. Okay. Yes. Difficult. So as far as thinking about the barriers of treatment, that is probably one of the biggest barriers of treatment. So I think another thing that I was told to kind of touch on was how to talk to a parent about eventually getting evaluated if there's suspicions as well for the child. So gaining insight and gathering information. So if you are with a parent that perhaps isn't fully accepting of autism, try to reflect on some of the concerns that they have. What is it that they want their child to kind of get help for? And does it sound kind of like some of the behaviors or the identified traits that neurodiverse clients have? So some of the things that Jasmine and Mackenzie had mentioned. Do they have a diagnosis maybe of OCD, of sensory processing disorder, the auditory processing disorder? Sometimes PTSD and anxiety also go along with autism as well. So autistic individuals sometimes experience the world as if you have PTSD, right? So if the world is a little bit too much, that flight or fight instinct is really what's causing some of those behaviors. So inquire with your parents, what are some of those developmental milestones and risk factors that were mentioned prior? What did we do during those times? Where did they have access to treatment for that? So, and then introduce some of the specifics and characteristics of autism. So just like what they had mentioned before was, if you meet one autistic individual, you're meeting one autistic individual. So I have a variety of clients that either are super excited and come running up to me and want to be fully engaged, or I have some clients that maybe are what we call stimming. So they're maybe waving something around in front of their face because it just looks so cool and it makes them kind of calm and regulated. So giving some common misconceptions to parents too, hopefully you can give a buy-in. So autism and being autistic is not a bad thing. It is not a bad word. So I think that is something to also kind of try to talk to parents about. Just because they have autism does not mean that anything is wrong with them. Their brain is just wired differently, just like ADHD, right? Just like, you know, any of the other things that could be considered in a neurodiverse client. When you're also giving psychoeducation to a parent that potentially has a child or any sort of kid in their family, or if they're a caregiver, give them an overview of the support services and why they're there. So whether it's speech language pathology, is their child not talking? Is your client, you know, not responding to anything? Are they being isolated often? Some of the things that occupational therapy helps out with too is motor coordination. Is it hard for the clients to clean up after themselves? You know, sometimes parents think their kids are just being lazy and defiant and they just have bad manners, or they're being naughty. No, maybe they just really have a hard time doing that motor planning, meaning that executive functioning really isn't there yet. It's there, but we have to teach it. If we're not showing this, which is also kind of a barrier to treatment, if we have parents that don't have the buy-in and they're not reflecting it, they're not narrating it, they're not showing it, then we're not also giving that child or youth that opportunity to learn it as well. So that's another thing to kind of keep in mind too when you're working with families. I know it's difficult. I've worked with residential populations too, so props to you as well. So I know that whatever work you guys are doing with these youth, as hard as it is, they are truly feeling it too, which is also why they're probably flip-flopping with their parents too. Also, when you're talking to the parents, make sure that we have resources on where to get evaluated. So they mentioned the ADOS. So that's ADOS. Look that up online in their surrounding areas that maybe their youth or their child are living in. So then that way they're not feeling like, what do I do next? So quite often parents that come in and talk to us, they feel very lonely and isolated because they don't know where to go with this information. So I always recommend trying to find any sort of clinician or anyone that is familiar with neurodiversity, people that understand what autism is, and that it's not just these super intelligent people that can memorize an entire movie and are depicted in movies as well, or you know, all the doctors, I forgot what doctor television show it is, but you guys kind of know what I mean. There seems to be that there's these people that think that autism is either that way high end of the spectrum or the low end, right? It's not high or low as far as functioning, it's support needs, okay? We have a lot of children that are at our center that people might refer to as low functioning if they do not know the child, but they fully understand everything that we're saying and doing. They just have a different way of communicating. Another thing I recommend is support groups for parents and other family members. So I work with a lot of the siblings. So as you all know too, when you're working with an identified client, you're working with the whole family. So having a child's sibling understand and can kind of support as well is wonderful. And giving that child the support, saying like, hey, I know maybe that you have a brother or sister that requires a lot of needs right now. What can we do to kind of help facilitate that knowledge and understanding of what autism really is? We offer support groups too at Blossom for male and female caregivers. So that way people can feel less isolated and understand that, hey, autism kind of does suck up all the energy in some parents right now. So having other people that can give you feedback and motivation and give you a little bit of a light at the end of the tunnel is very important. Another thing to recommend, if you do have a youth that's still seeing pediatricians, find one that's a developmental pediatrician, back of ways that they wish things could have been differently as they were growing up. And I believe that some of the youth maybe that you guys work with that are older could possibly see different accounts and opportunities that might be inspirational, or they kind of resonate with it. Not receiving a diagnosis or seeking the label early may lead to resentment or feelings of isolation. A lot of adults that are in that autistic community are looking for a diagnosis as they're older, so they're getting that sense of clarity and understanding, oh, life maybe didn't have to be this hard. If I had known that this is why I'm feeling so different maybe than other people. So just kind of going back to the basics, building rapport and trust, gain insight and reflection on presenting concerns when you're talking with parents, provide psychoeducation on autism spectrum disorder, prepare for difficult reactions by anticipating them. And if they're not difficult reactions, awesome. Have resources, support services and groups ready when you do have that conversation with the parent, so they're not feeling like, what do I do next? Here are some different accounts that we recommend for advocacy, treatment, and acceptance.
Do you all work with adults who are diagnosed with autism?
I don't right now, but are you just asking for like people you work with now?
Yes, because I work with adults and I don't know if it's just the fad of social media, but it just seems like a lot of individuals are being diagnosed with later in life, or there's more access to resources. So I'm just curious about, as far as resources in the area for adults, or if they're questioning, and maybe they've used substances to cope, or
Sure.
drugs to cope, and so just trying to figure out ways to help them to figure out how to live a greater quality of life.
Right.
We're talking about.
And you made up a good point. So a lot of autistic adults too have learned how to mask. So that really is what you're talking about too, is like, okay, I've learned that maybe the world isn't accepting for these different things that I do, so I'm gonna act like a different person. So I always like to use the term like, I'm gonna become a chameleon, right? I know I'm gonna feel like fit this way, or maybe I'll use substances to make me feel a little bit better, and then less anxious to communicate, with other people. That really is common that you're saying that. Actually, not far from here, there's a place called the Living and Learning Center in Northville. They work with autistic adults, and they have lots and lots of resources for it. They're also a nonprofit organization. They offer art therapy there as well too, and they also have like a little shop downtown in Northville that's run by some of their people that come there. So I would recommend them. But I would also just look up on like Psychology Today too, and see if there's people that are specifically inclusive of autistic individuals too.
The Friendship Circle also has some good groups for more like adolescents and older childhood, not adults necessarily, but
The
some
Friendship
teen
Circle.
Friendship Circle. It's might be a good resource for group activities, sports activities,
They do a lot of
recreational
groups, too.
groups for autistic adolescents or older childhood.
So a couple questions. You may have covered this, but who refers kids to you guys?
So we get a lot from pediatricians. Who else do you get?
When kids are really young, the first thing doctors will say is like, oh, they're not talking, go see a speech pathologist. So a lot of times the speech pathologist will be like, okay, I see differences. It's not just communication, it's social interaction, it's play. And then we would refer on for an evaluation. Schools can identify it too. And so it's really that early intervention, like getting into providers first to see like, okay, this isn't just this, it's a bigger thing. But doctors, and then that first line of therapy is who typically will see it.
You said you guys typically work with kids up to 8.
Mm-hmm.
but, so like, is there a process to where they like age out of your program, or like, what's the oldest kid you guys work with? Like,
So the goal of our program is to transition our kids into school. So we don't want them to be with us forever because that's not the most natural environment for them. The next place would be to get into a school program, so that's kind of why we have that age of 8. So we really, once they get to 8, they have a team of therapists they've been working with it. Up to that point, we would work with the school to get them into a school program that would be best suited for them.
For the counseling and art therapy department, we offer private clients to up to age 12. So we do work with some older kids.
What age do you start? Like, what's the youngest?
So a diagnosis is most, they're finding like it's most likely the right diagnosis for them at age 2. So you can really see the differences. Even like at 1.5, you can see them, but they say that a diagnosis at 2 is reliable.
Yeah, and that's kind of where most of our kiddos start at, right?
Again, it depends on who's noticing. If the parent, it's education too. If a parent doesn't, if it's their firstborn and they don't have other kids to compare to, they might not know. They might just think, especially in a COVID world too, it's like they are not around other kids. They're not around seeing what other kids are doing. They might not be like, oh, my kid's not doing that. Or that's not what their sibling did. So it can be harder and it can take longer to get a child evaluated
And that's really impacted, obviously, everyone too, the pandemic. So a lot of our kiddos have felt that too.
And different doctors have different levels of when they're gonna refer somebody. They might be like, oh, it's okay, let's wait and see. And other doctors are like, no, let's get that looked at. I'd always recommend if a parent has concerns to get an evaluation for what they're concerned about. The earlier the better.